This is the first talk of this Ultrasound the Best Cases webinar, and I will show you several example cases of ultrasound the best in the urinary tract, and after that I will talk more detail about nutcracker syndrome. This is the first example, 45-year-old man with cystic renal cell carcinoma. Here is a cystic mass at contrast-enhanced CT, and there are suspicious fine enhancing septa. Contrast-enhanced ultrasound was done, and it clearly shows thick and irregular enhancing septa and enhancing mural nodules. These contrast-enhanced ultrasound findings are strong evidence of cystic renal cell carcinoma, and the surgery and pathology confirmed cystic renal cell carcinoma of clear cell type. In this case, contrast-enhanced ultrasound showed enhancement of the internal structures of a cystic mass much better than contrast-enhanced CT, and contrast-enhanced ultrasound is much more sensitive than contrast-enhanced CT or MRI in showing subtle enhancement. Here is another nice example showing the high sensitivity of contrast-enhanced ultrasound. This is a 44-year-old man with end-stage renal disease. Ultrasound and CT show end-stage kidney and multiple renal masses of mixed cystic and solid-looking components, but vascularity at color Doppler ultrasound or enhancement at contrast-enhanced CT is not definite. Contrast-enhanced ultrasound well shows the movement of microbubbles in the solid-looking area, indicating that this is a viable solid tumor portion, and it was confirmed as a renal cell carcinoma of unclassified type. The next example of ultrasound the best in the urinary tract is the value of so-called ultrasound sliding sign in large renal cell carcinoma. Two different cases of large renal cell carcinoma of the left kidney and the descending colons are close to the renal masses and possibly involved by renal cell carcinomas, which is important to the urologic surgeons. Ultrasound is very useful in assessing this point by observation of the movements of the renal mass and the descending colon during inspiration and expiration. If there is a sliding or different movements between the mass and the colon, like this case on the left side, it means that there is no adhesion or invasion. But if two structures are moving together without sliding, like this case on the right side, it means that there will be adhesion and invasion that the surgeon needs to prepare for this before surgery. This example of ultrasound the best showed that ultrasound has a unique ability to determine the movements of two adjacent organs either together or separately during respiration, which was called the ultrasound sliding sign. And the ultrasound sliding sign is very useful in the evaluation of local invasion of a tumor into an adjacent organ. The next example of ultrasound the best in the urinary tract is the ultrasound in patients suspicious of diabetic nephropathy. One characteristic feature of kidneys in diabetic patients is that the kidneys appear quite normal even in advanced diabetic nephropathy. Therefore, it is difficult to evaluate the severity of diabetic nephropathy with grayscale ultrasound images only, but spectral Doppler ultrasound may show the difference in blood flow. It is known that resistive index values in those patients are well correlated with renal functional status, creatinine clearance values, and well reflect the severity of nephropathy in diabetic patients. This is the case I showed you before in the introduction time, and I believe this is the best of the best example of ultrasound the best in the urinary tract. This is a 45-year-old man with proteinuria and microscopic hematuria caused by nutcracker syndrome. Ultrasound images in flat supine position show markedly dilated left renal vein caused by discompression between the aorta and the superior mesenteric artery. And color Doppler ultrasound shows jetting of bright high-velocity flow through the narrowed aortomesenteric portion of left renal vein, and peak flow velocity was around 3 meters per second. When the patient takes a lateral decubitus position, left renal vein is suddenly collapsed, and now peak velocity is much lower, 127 centimeters per second. So in this patient, ultrasound was the best modality to find out the cause of his proteinuria and microscopic hematuria, and the information of ultrasound findings with posture changes is helpful to the patient. I had a special interest in this nutcracker syndrome, and this is the article I wrote in 1996, and this is the review article I wrote last year. Nutcracker syndrome is caused by compression of left renal vein between the aorta and the superior mesenteric artery, resulting in left renal vein hypertension. Intermittent growth hematuria is the most typical symptom, but instead the patients may have microscopic hematuria, proteinuria, or left flank pain. The incidence of this syndrome is unknown, but it is generally thought rare. Nutcracker syndrome is registered as a rare disease in the United States at NIH and orphanage sites, but I believe it is probably not as rare as it is known. The reason why I believe this syndrome is not rare and is probably quite common are a quite high incidence of microscopic hematuria or proteinuria in health screening in students and adults, and the significantly dilated left renal vein was a very common finding at all the ultrasound studies. This is the title of this article in AJR. Before we go further, we need to make the difference between the two terms nutcracker syndrome and nutcracker phenomenon clear. Nutcracker phenomenon is just a phenomenon itself, and we may call it nutcracker syndrome only when this phenomenon is associated with related symptoms or signs such as hematuria, proteinuria, and or left flank pain or discomfort. And of course, we do not call it nutcracker syndrome if there are other causes of those symptoms or signs, such as underlying renal parenchymal disease or left renal stones, etc. So the diagnostic criteria of nutcracker syndrome is first, there should be no other causes of hematuria or proteinuria, and it will be helpful if there is a high proportion of isomorphic RBC in the urine or left-sided hematuria on cystoscopy, but definite diagnosis can be made when venous catheterization reveals more than 3 mm mercury pressure gradient, but it is an invasive procedure. Because nutcracker phenomenon is a common in slender people with small amount of retroperitoneal fat and prominent lumbar lordotic curve, left renal vein diameter and the aortomesenteric angle may be used to suspect the phenomenon, but it is difficult to use these values in diagnosis because there is too much overlap between patients and normal groups. So, Doppler ultrasound will be the best imaging modality to show left renal vein and to measure flow velocity. In normal people, flow velocity on this hilar portion of left renal vein is usually between 15 and 20 centimeters per second, while it is around 40 to 50 centimeters per second in this aortomesenteric portion of left renal vein. This 50 cm per second equals 1.8 km per hour, which is a speed we walk very slowly. If the peak flow velocity at aortomesenteric left renal vein is higher than 80 to 100 cm per second, we can strongly suspect nutcracker phenomenon or syndrome. Here is an example case of nutcracker syndrome. 15-year-old male with gross hematuria. Peak velocity at aortomesenteric left renal vein was 152 cm per second, which is about 3 times higher than normal value, and the pressure gradient was 6 mm mercury. Another case, 19-year-old male with gross hematuria, flow jetting here, peak velocity was 112 cm per second, and pressure gradient was 4 mm mercury. 28-year-old female with a long history of proteinuria, and grayscale and color Doppler ultrasound will show narrowing of left renal vein between aorta and superior mesenteric artery, and high velocity jetting, and measured peak velocity was 147 cm per second. Because this patient has no other cause of proteinuria, we may call this case as a nutcracker syndrome. How about this case? 56-year-old woman with microscopic hematuria and proteinuria, but this case has a significantly different appearance. In this patient, left renal vein is compressed not between the aorta and the superior mesenteric artery, but is compressed by anteriorly arising right renal artery. You can see bright color jetting from this point. So this is a case of nutcracker syndrome with left renal vein compressed by right renal artery. Here is another example of nutcracker phenomenon, 72-year-old man without hematuria or proteinuria. In this patient, abdominal aorta is prominent, but the space between the aorta and the superior mesenteric artery is not narrow. Instead, the left renal vein appears stretched over the aorta, and we see bright colored jetting after left renal vein meets the aorta. CT also shows left renal vein stretched over the aorta and jetting of contrast opacified flow. The peak flow velocity was 127 cm per second. From those cases we saw, we may say that there are at least 3 patterns of nutcracker phenomenon. Type 1, classical compression at narrow space between the aorta and the superior mesenteric artery. Type 2, compression by anteriorly arising right renal artery. And type 3, left renal vein stretched over the aorta. Let's see a few more cases. 48-year-old woman, no hematuria, no proteinuria. Peak flow velocity is 165 cm per second, and if you look at the grayscale ultrasound and color Doppler ultrasound, you may make a diagnosis of nutcracker phenomenon type 2, left renal vein compression by the right renal artery. Another case, 58-year-old woman with proteinuria, 127 cm per second peak flow velocity. The space between the aorta and the superior mesenteric artery is not narrow, nor compression by right renal artery, but left renal vein is stretched over the aorta, so we may call this case type 3 nutcracker syndrome. This is a 33-year-old woman with microscopic hematuria and proteinuria. Grayscale and color Doppler ultrasound show compression of left renal vein at 2 sites, one in between aorta and the superior mesenteric artery, and the other by right renal artery, with peak velocity of 108 and 125 cm per second, respectively. So we may classify this case as nutcracker syndrome type 1 plus 2. The next thing I want to mention is that nutcracker phenomenon or syndrome is not a fixed condition, but a condition of a big spectrum. I already mentioned the 3 subtypes or patterns of nutcracker. I also want to mention about the variation of Doppler ultrasound findings according to the posture of the patients. I already showed you this case, and there is a big difference of left renal vein dilatation at supine and lateral decubitus position. Here is another case, 35-year-old man with microscopic hematuria, proteinuria, and left flank discomfort caused by nutcracker syndrome type 1. In the supine position, left renal vein is compressed at aortomagnetic portion with prominent jetting at color Doppler ultrasound, and peak flow velocity was 141 cm per second. With the patient in lateral decubitus position, superior mesenteric artery is here, and left renal vein compression is markedly relieved. Also, peak flow velocity was markedly decreased, 51.8 cm per second. This Doppler information according to the patient's posture will be helpful to the patients. This is a 53-year-old woman with microscopic hematuria and proteinuria. These are color Doppler ultrasound images at supine, left lateral decubitus, and right lateral decubitus positions. In supine and left lateral decubitus positions, the findings are type 3 nutcracker, left renal vein stretched over the aorta, but in right lateral decubitus position, it looks like type 1 nutcracker. So again, it is not a fixed condition but has spectra and variations. I would like to finish my talk by summarizing that nutcracker phenomenon and nutcracker syndrome are probably not rare but quite common. To make a diagnosis of nutcracker phenomenon or syndrome is important both for the patients and the physicians. And keep in mind that nutcracker phenomenon or syndrome have subtypes and variations according to the patient's posture, and Doppler ultrasound is the best. Thank you for joining this session, and I strongly recommend you to join WFUMB Ultrasound the Best campaign by submitting your Ultrasound the Best cases to WFUMB.